Bismillahirrahmanirrahim. So now we will start with the last session of our 180 points. I will try to keep that confine that within the 50 minutes, but if it takes longer than that, so be ready for that because it may take longer because we have to cover some 46 pages or 45 pages maybe in the session. So let's get straight into it. The first point is layers of the scalp. So there are like 1, 2, 3, 4, 5 important layers. Number one is skin. That is sebaceous cyst can form in this layer. So here you can see the skin. Number two is dense connective tissue. So superficial scalp lacerations do not gape and result in severe bleeding. So the lacerations, they will not gape and they will result in severe bleeding if they damage the connective tissue, the dense connective tissue. Then the point number three is aponeurosis. So point number three is aponeurosis, like over there I guess the skin and then connective tissue. And then point A, that is aponeurosis, that is epicranial laceration through three superficial layer gape widely because of contraction frontalis and occipital part of the occipital frontalis muscle. I could not understand that one. Aponeurosis or epicranial lacerations through three superficial layers like skin and the connective tissue, and this point aponeurosis, they will gape widely because of contraction of frontalis and the occipital part of the occipitofrontalis muscle. So I guess if there is laceration like that, so there will be contraction of frontalis anteriorly and the occipital posteriorly, and there will be large gap or there will be big lacerations. Okay, then the point 4, that is loose areolar tissue. So this one, so the mnemonic is also scalp. So the fourth layer is the loose areolar tissue. So the dangerous area of the scalp, it contains the potential spaces capable of being distended with the fluid resulting from the injury or infection. And the point 5, the fifth layer is pericranium, that is bleeding between the pericranium and calvaria during a difficult birth, present in the cephal hematoma, typically limited by the borders of parietal bone. So remember these 5 layers: skin, deep connective tissue, aponeurosis, loose areolar tissue, and the pericranium. And this loose areolar tissue is the dangerous area of the scalp. It contains the potential spaces capable of being distended with the fluid resulting from the injury or infection. Point number 73 is about the cranial foci. So anterior cranial fossa contains the frontal lobe. So there are three cranial foci: anterior, middle, and posterior. So the anterior cranial fossa contains the frontal lobe, like this one. So this is the frontal lobe. Dura mater is supplied by the V1 or the anterior meningeal V1, that is the first branch of the trigeminal nerve, that is ophthalmic. Yep, ophthalmic nerve. The dura mater is supplied by the ophthalmic nerve and the anterior meningeal artery from the ethmoidal artery. The middle cranial fossa, that contains the temporal lobe. Okay, so it will be like housing the temporal lobe. Dura mater is supplied by the V2 and V3, that is maxillary and the mandibular branches of the trigeminal nerve and middle meningeal artery from the maxillary artery. The posterior cranial fossa contains the cerebellum, like this structure is cerebellum. So this is contained within the posterior cranial fossa, and dura mater is supplied by the spinal nerves via CN10 and CN12 and the posterior meningeal artery from the ascending pharyngeal occipital arteries. So remember these innervations and the blood supplies to these foci. Moving forward to the point number 74, that is fracture of the anterior cranial fossa. If there is fracture to the anterior cranial fossa, which will look something like that. So fracture of the anterior cranial fossa, cribriform plate of the ethmoid bone, is suggested by anosmia, periorbital bruising, raccoon eyes, like these are the raccoon eyes, and CSF leakage from the nose. Okay, so there will be CSF leakage from the nose. That is called as rhinorrhea, CSF rhinorrhea basically. Then what is termed by epidural hematoma? So if there is hematoma that is developing outside the dura, that is called as epidural hematoma. Skull fracture near the pterion often causes the epidural hematoma from the torn middle meningeal artery, foramen spinosum. So the middle meningeal artery can be torn from the foramen spinosum, so that will result in the epidural hematoma. Unconsciousness and death are rapid because the bleeding dissects the white space as it strips the dura from the inner surface of the skull, which puts the pressure on the brain. Then epidural hematoma forms a characteristic biconvex pattern on the computer tomography images because it cannot cross the suture lines. So that will form a biconvex lentiform pattern, like it will form like a lens. And here you can see a epidural hematoma is over there, and an epidural hematoma can also be seen over there. So because the pressure is being exerted on the brain, there will be midline deviation. So deviation from the midline will be there on the opposite side, and there will be excessive pressure applied on the brain, and the vital structure of the brain can be compressed, or the brain herniation, specifically the brainstem, if that is herniated below from the foramen magnum due to the pressure effects of the epidural hematoma, that can lead to rapid death. So the skull fracture, unconsciousness and death are rapid in the case of epidural hematoma. cavernous sinus infection, dangerous triangle of the face. So this thing like this, including the upper lip and this area is the dangerous triangle of the face. So the middle third of the face is a danger area because infection there may produce thrombophlebitis of the facial angular vein. Okay, so facial angular vein, this is the facial angular vein that can spread to the cavernous sinus via superior ophthalmic vein. Okay, so it can spread via superior ophthalmic vein to the cavernous sinus that is located over. No, that's not cavernous. That is very good. Here we have the cavernous sinus. So it can spread to the cavernous sinus via superior ophthalmic vein, facial vein, superior ophthalmic vein, facial vein, then to the superior ophthalmic vein, and from there into cavernous sinus. The septicemia leads to meningitis and the cavernous sinus thrombosis. Okay, so septicemia will lead to meningitis and cavernous sinus thrombosis, like thrombosis in this cavernous sinus, both of which can cause neurological damage and are life-threatening as well. Second possible route of the infection, it can spread from upper molars via pterygoid venous plexus. So here we have the pterygoid venous plexus. If there is infection in the teeth, so that can ascend upwards via pterygoid venous plexus to the inferior ophthalmic vein, pterygoid plexus, inferior ophthalmic vein, and the cavernous sinus. From pterygoid venous plexus to the inferior ophthalmic vein, like where is the inferior ophthalmic vein? This one, the fifth one. This is the inferior ophthalmic vein. So pterygoid to the inferior ophthalmic vein all the way to the cavernous sinus. This can happen as well. Cavernous sinus thrombosis. So what are the side effects? So what are the symptoms of that? Not side effects, symptoms. So structures that may be affected by the cavernous sinus thrombosis are structures that pass directly through the sinus that are internal carotid artery in the case of laceration. So there will be arteriovenous fistula. So if we could see it, so here you can see like this structure and the highlighted structure which I am highlighting right now. This is the cavernous sinus. So here you can see the internal carotid artery that is passing, the cavernous part of the internal carotid artery is passing right through the cavernous sinus. So if there is damage or laceration to that, so this artery will start communicating with the veins. Now cavernous sinus is a channel of veins, while the internal carotid artery is an artery. So if there is connection between these two structures, so there will be an arteriovenous fistula that is also called as there's some name to that, I guess. I don't know, carotico-cavernous fistula, I guess it is called that. So the carotico-cavernous fistula will lead to severe, hemodynamic changes in the heart because there will be increased venous return and a lot of changes which we saw in the CVS session and which we'll later discuss in that session as well. So there will be a lot of changes in the CVS session because of the formation of this fistula, because afterload is dramatically reduced and the peripheral resistance has been decreased. So resultantly there are a lot of changes which we see in these sessions, in these things. So structure that pass through the sinus, internal carotid artery in case of laceration, arteriovenous fistula will be formed, and abducens nerve CN6 in case of lesion of the internal. So there will be internal squint, because here you can see that abducens nerve is in intimate relationship with this, the cavernous part of the carotid artery. So if there is any damage to this carotid artery over there, so the abducens nerve will be damaged, and we know that abducens nerve is going to supply the lateral rectus, which is responsible for lateral movement of the eye or abduction of the eye. If the lateral rectus is damaged or the abducens nerve is damaged, resultantly the lateral rectus will not perform its activity and the eye will be internally deviated, that is called as internal squint. Structure on the lateral wall of sinus. Number 1 is oculomotor nerve, that is CN3, trochlear nerve CN4, ophthalmic nerve CN51, and maxillary nerve CN52. So on the wall we have the oculomotor nerve CN3, trochlear nerve CN4, and then ophthalmic and the maxillary nerve CN51 and CN52. Then point number 77 is about the cranial nerves. So this is a smart table. S is for the sensory, M is for the somatomotor, P is for the parasympathomimetic and secretomotor. So let's talk about the nerves. Olfactory nerve, we are talking about the nerves, like all of the nerves. So all of the cranial nerves. Number 1 first nerve is olfactory nerve. It is sensory and it passes from the cribriform plate. Function is to smell, and lesion will cause anosmia. Optic nerve is also purely sensory nerve. It passes through the optic canal. The function is vision, and lesion will lead to visual defects, anopsia, or loss of light reflex, because it is this thing, the optic nerve is the afferent limb of the light reflex. The light reflex is the one in which you shine the light in an eye, and both eyes, the pupil of both eyes will constrict. So that is basically light reflex. So optic nerve, if there is a lesion to the optic nerve, so resultantly, first thing is that there will be visual defects, that is anopsia, and secondly there will be a loss of light reflex along with CN3. So basically even if the optic nerve is damaged, there will be loss of light reflex, although the motor component is intact, that is CN3, but since the sensory is not functioning properly, so the pupil will not react to the light. Then oculomotor nerve is motor plus parasympathomimetic secretomotor. So oculomotor contains motor fibers as well as the parasympathetic fibers coming from the Edinger-Westphal nucleus, superior orbital fissure and ciliary ganglion. So oculomotor nerve, it passes through the superior orbital fissure. There are a lot of things, there are a lot of nerves which will follow now, that will be passing through the superior orbital fissure, and it also is associated with the ciliary ganglion. The parasympathetic fibers which are carried by the oculomotor nerve will relay in the ciliary ganglion, and then they will come out as, I guess, long ciliary nerve, maybe, I guess long ciliary nerve. So it raises the eyelid. The function is to raise the eyelid, moves the eyeball in all direction, constricts the pupil, and also cause the accommodation, helps with the accommodation. The lesion will cause external strabismus with ptosis and dilated pupil, and there will be loss of light reflex. The motor pathway or the motor or the efferent limb of the light reflex is coming from the CN3, while the afferent was coming from CN2. The trochlear, the fourth nerve, that is also absolutely motor. It is supplying the so there is a formula like that, that is what was that, SO4 LR6 and AO, all other by 3. So the oculomotor nerve is supplying all of the extraocular muscles, including the superior rectus and the medial rectus and the inferior rectus and the inferior oblique. The trochlear nerve is supplying the SO4, that is superior oblique. It is purely motor nerve. It passes through the superior orbital fissure. The function is to depress and abduct the eyeball. Lesion is trouble reading and going downstairs. Okay. Then the cranial nerve 6, that is abducens nerve, that is also purely motor. It is also passing through the superior orbital fissure, and it supplies the lateral rectus. It abducts the eyeball, and the lesion to that will result in internal strabismus, as we saw in the cavernous sinus thrombosis. Then we have trigeminal nerve. So trigeminal nerve has 3 divisions, V1, V2 and V3. So the lesion will result in trigeminal neuralgia, and it is associated with the trigeminal ganglion as well. It relays in that, I guess. Then we have V1, that is ophthalmic nerve, that is purely sensory, and it also passes through the superior orbital fissure. Yes, so it passes, so we'll discuss the mnemonic as well. So it passes through the superior orbital fissure. The function is general sensation, touch, pain and temperature of the forehead, scalp and the cornea and nose. The lesion will result in loss of the general sensation in the skin, forehead and nose, and also the loss of blink reflex along with the CN7. So the afferent limb of the blink reflex or the corneal blink reflex is coming from the CN51, while the efferent or the motor reflex is coming from the CN7. That will cause the contraction of the orbicularis oculi, and that will lead to the blinking reflex activity. Then V2, that is the maxillary nerve, that is also purely sensory, and it is present in the foramen rotundum. The function is general sensation of the palate, nasal cavity, maxillary, face and upper teeth, and the lesion will result in loss of general sensation in the skin over the maxilla and the upper teeth. The V3, that is mandibular nerve, that is sensory as well as motor, and it is present in the foramen ovale. General sensation not present, basically it is passing through the foramen ovale, and this was passing through the foramen rotundum. So general sensation of the anterior 2/3 of the tongue, mandibular and face and lower teeth, motor to 4 muscle of mastication, 2 oral floor and 2 tensors. Loss of general sensation in the skin over mandible, lower teeth, anterior 2/3 of the tongue, weakness in chewing, jaw deviation towards the weak side. So there will be deviation if the mandibular nerve is damaged. The jaw will be deviated towards ipsilateral basically, or towards the weak side. So it is like for remembering the foramina for the trigeminal nerve, you can remember the mnemonic okay, it's very hard to write it like that. Standing room only. If I could write it like standing room only. So standing room only, it will take some time to appear. So standing room only mean like the ophthalmic nerve is present in the superior orbital fissure, and the maxillary nerve is present in the foramen rotundum, and the mandibular nerve is present in the foramen ovale. So there you go with the mnemonic. Standing room only. It is not room, it is room only. So but it takes time to appear. So standing room only, which means that as if for the superior orbital fissure, the V1 is present in the superior orbital fissure, the V2 is present in the foramen rotundum, while the V3 is present in the foramen ovale. Pardon me for the bad spellings. Moving forward to the CN7, that is facial nerve. Facial nerve is motor plus sensory plus parasympathetic, that is secretomotor, right? Parasympathetic and secretomotor. So the facial nerve that is present in the internal auditory meatus, that passes through the internal auditory meatus and the geniculate ganglion, then submandibular ganglion and the pterygopalatine ganglion. So these are the three ganglions through which it passes. Geniculate ganglion, I guess, is sensory, and the submandibular and the pterygopalatine are secretomotor ganglia. Function is to the muscle of facial expression, stapedius. Okay, so it gives innervation to the muscle of facial expression to the stapedius. Okay, stapedius is present in the ear, and that is responsible for decreasing the intensity of the sound. So if facial nerve is damaged, so the people are suffering from hyperacusis. There is a thunderstorm that is going on outside right now. I'm sorry. So yeah, taste of anterior two-thirds of the tongue is taken by the facial nerve, by the coda tympani branch of the facial nerve. Then secretomotor for the submandibular, sublingual gland. Secretomotor for the submandibular and sublingual gland via submandibular ganglion, and lacrimal gland and the nasal palatine, lacrimal gland, nasal and palatine gland via pterygopalatine ganglion. Lesion can result in Bell palsy, hyperacusis because of the loss of stapedius reflex, then loss of the blink reflex. The motor, we have seen previously that the efferent limb of the blink reflex is coming from the CN7, while the afferent limb of the CN5 is coming from the afferent limb of blink reflex is coming from CN5. Loss of taste, anterior two-thirds, and eye will be dry and red. So the eighth nerve is the vestibulocochlear nerve, that is purely sensory. Internal auditory meatus, it is present in the internal auditory meatus, and it is associated with a spiral and vestibular ganglion, and both of these ganglia are sensory. The spiral ganglia is resultant with is associated with the hearing, while the vestibular ganglia is associated with the linear and angular acceleration. Sensory neural hearing loss and loss of balance will also be there. The ninth cranial nerve, that is glossopharyngeal nerve, it will be motor plus sensory plus parasympathomimetic or parasympathetic, basically, or secretomotor. So jugular foramen, it passes through the jugular foramen along with 9, 10, 11. These are the three nerves that are present in the jugular foramen. I guess there is a Wernicke syndrome that is associated with these conditions if there is damage to the jugular foramen. So jugular foramen, superior and inferior ganglia and otic ganglia are associated with this. Superior and inferior ganglia are associated with a sensory functionality, while the otic ganglion is associated with a secretomotor function of the glossopharyngeal nerve. The function, it supplies the stylopharyngeus muscle, general and taste sensation from posterior one-third of the tongue via the superior and inferior ganglion. Okay, so posterior one-third of the tongue and pharynx and carotid and sinus body, that is very important. Carotid and sinus body sensation are also taken by the glossopharyngeal nerve. Okay, then secretomotor for the parotid gland. So remember that the baroreceptors from the carotid sinus are giving sensation via the glossopharyngeal nerve, while the aortic arch is giving sensation via the vagus nerve, and both the motor supply or the efferent fibers are coming via the vagus nerve in both these cases. So then we have, if there is lesion, so the gag reflex will be lost. So the afferent limb of the gag reflex is by the cranial nerve 9, that is glossopharyngeal nerve, and the efferent limb of the gag reflex is coming by CN10. Moving forward to the vagus nerve. So vagus nerve is motor plus sensory plus parasympathetic or secretomotor. It is also present in the jugular foramen. Superior and inferior ganglia are associated with this nerve, and the trigeminal ganglion is also an association for the secretomotor activity. Function is to the muscle of larynx, palate, pharynx, except the tensor palatini, and stylopharyngeus. I guess tensor palatini, I don't know what gives supply to that one, but the stylopharyngeus is supplied by the glossopharyngeal nerve. It also provides sensation in the larynx and laryngopharynx, and the parasympathomimetic activity of the parasympathetic supply will be given to the foregut and midgut, smooth muscle and glands. Okay, the lesion will result in dysphagia, palatal droop. Okay, uvula pointing away from the side of lesion. So there is a mnemonic about that in Urdu, that जुबान साथ देती है लेकिन uvula साथ नहीं देता, which means that tongue will move to the side of lesion, but the uvula will move to the opposite to the side of lesion. Okay, hoarseness, loss of vocal cord abduction, loss of gag reflex. The efferent limb of the gag reflex is mediated by the vagus nerve, or the motor component of that is mediated by the vagus nerve, while the afferent or sensory component of the gag reflex was taken by the glossopharyngeal nerve. And there will also be a loss of cuff reflex, I guess because of loss of sensation of the larynx and laryngopharynx. Point number 11 is about the accessory cranial nerve, that is also present in the jugular foramen. It turns the head to the opposite side due to the innervation of the sternocleidomastoid muscle, elevates and rotates the scapula, that is the function of trapezius muscle. Shoulder droop on the same side. So if there is damage to the accessory cranial nerve, so the ipsilateral shoulder will be drooped. Then cranial nerve 12, that is hypoglossal nerve. It is also purely motor, just like the sensory nerve, and it is present in the hypoglossal canal to the muscle of tongue and the intrahyoid ansa cervicalis. It's a very fancy name. I don't know what that is, but it is a very beautiful name. Deviation of the tongue toward the lesion side of protrusion. So on the same side of lesion, when we'll protrude the tongue will deviate to the side of lesion. Okay. Then we have point number 78, that is about the pituitary gland tumors and the transsphenoidal operation. So the pituitary tumors may extend superiorly through the opening in the diaphragma sella, producing the disturbance in the endocrine system. Superior extension of the tumor may cause visual deficit owing to the pressure on the optic chiasm. So where is optic chiasm? This thing, point number 2. Okay, so here you can see this is optic chiasm over here. So optic chiasm contain nasal fibers from both these. The decussation of the nasal fibers from both the eyes. So the optic chiasm can be pressed by these pituitary tumors, the place where the optic nerve fiber crosses. The transsphenoidal operation is most common operation for the pituitary tumor. The surgical approach for it is through the nose, nasal cavity, and the sphenoidal sinus. Okay, we move to the nose and then nasal cavity, and then we go to the sphenoidal sinus. So here we have the sphenoidal sinus, nose, nasal cavity, and then this is sphenoidal sinus over there. And from sphenoidal sinus we approach the pituitary. This surgical approach provides the best exposure to the tumor at the lowest risk. What are the hormones of the pituitary gland? So releasing an inhibitory factors from the neurosecretory cells of the hypothalamus reach the pituitary gland through the special Capelli network, that is the hypophyseal portal system, and control the production of adenohypophyseal hormones, which are anterior pituitary hormones, which are ACTH, FSH, LH, TSH, prolactin, and somatotropin. Hormone of neurohypophysis, which is posterior pituitary, are ADH and oxytocin, are secreted in hypothalamus. They are basically produced in the hypothalamus and transported through the axon to the posterior pituitary. Okay, so here you can see that this is the anterior lobe, and it is connected with the hypothalamus by the hypothalamic hypophyseal circulation, and the releasing factor are coming from the hypothalamus into the circulation, which approach this pituitary, and then from the anterior pituitary, the cells which are present in the anterior pituitary will be stimulated or inhibited to release hormones, and the hormones will then be released by the pituitary gland vein into the circulation. While in the case of posterior pituitary, then the neurons from the hypothalamus are coming downwards, and neurons will take the pre-synthesized ADH and oxytocin into the posterior pituitary, and then from the posterior pituitary they are released into the circulation by the posterior venous circulation. Then we have the point number 17, that is about trigeminal nerve. So the skin of the face is supplied by the branches of 3 divisions of the trigeminal nerve, CN51. So here you can see that the green branches are supplying the area on the forehead and the scalp area, that is ophthalmic nerve, that is CN51. Then we have maxillary nerve, that is supplying the maxillary area, okay, V2, and the mandibular area. The mandibular nerve is supplying, taking the sensory information from the mandibular part of the face, and also it is going to supply the muscles of mastication, which are medial and lateral pterygoid, masseter, and the buccinator muscle. Except for a small area over the angle of mandible, which is supplied by the great auricular nerve and cervical plexus. So I guess over here there is some area that is being supplied by the great auricular nerve or the cervical plexus. The rest of the area is being supplied by the trigeminal nerve all over the face. The sensations are basically taken by the trigeminal nerve. Okay, what is Bell's palsy? That is the 80th point. So that is about Bell's palsy. It is idiopathic, very important point. If we are labeling it Bell's palsy, it is supposed to be idiopathic. It is idiopathic unilateral facial paralysis. Terminal branches of CN7 may be injured by parotid cancer or inflammation, that is parotitis, by the surgery to remove the parotid tumor that is found in the stylomastoid foramen. Okay, so terminal branches of CN7 may be injured by the parotid cancer or inflammation, parotitis, by the surgery to remove a parotid tumor in the stylomastoid foramen. Manifestation: unable to close the lips and eyelids on the affected side. Eye on the affected side is not lubricated, that there will be dry eye because this eye cannot be closed. So that will become dry. Unable to whistle, blow a wind instrument, or chew effectively. Okay, because like orbicularis oris, pardon me, this eye is closing properly, this eye is open. So orbicularis oris cannot function in this side, and facial distortion to the contraction of unopposed contralateral facial muscle. So whenever the person is like moving his face, so there will be movement or deviation of the mouth to the contralateral side of lesion. But I'm not saying the contralateral side of lesion toward the normal side, because the side of lesion is variable. We saw that in the neuro sections. So due to the contraction of unopposed contralateral facial muscles. Then we have epistaxis. Epistaxis means blood coming out of the nasal cavity. Epistaxis or the nosebleed most often occur from the anterior nasal septum due to the casal back area. From the casal back area, this is the casal back area. It is present on the antero-inferior part of the nasal septum, where the branches of sphenopalatine, anterior ethmoidal, greater palatine, and the superior labial from the facial artery converge. What are the 4 arteries which converge over there? Sphenopalatine, anterior ethmoidal, greater palatine, and the superior labial. So they will converge over here, and resultantly there will be nosebleed, which looks something like this, and that is coming from the caudal back plexus. There are also some plexus over here, like the, I guess over here, the Woodruff plexus over there, which causes the posterior, post nasal drip of the blood, and there are some other sites of epistaxis as well, but the caudal back plexus is the most important one. Then lateral wall of the nasal cavity, which contains the conchae, so sphenoethmoidal recess. So what is that? Sphenoethmoidal recess receive opening of the sphenoidal air sinus. Then we have superior meatus. It receives the opening from the posterior ethmoidal air cells. Middle meatus contains a lot of openings. So suppose that it is not a very clear picture. Suppose that here is a nasal cavity. So these are conchae, superior, middle, and inferior concha. So sphenoethmoidal recess, if they have made that sphenoethmoidal recess, where is sphenoethmoidal recess? Spinosinus sphenoethmoidal recess. Okay. So let me zoom it in. So here you can see the sphenoethmoidal recess, which is receiving the contents of the sphenoidal sinus. So the sphenoethmoidal recess receives the opening of the sphenoidal air sinus. The superior meatus that is present under the superior concha. So superior meatus is over there. So the opening of the posterior ethmoidal air cell will enter the superior meatus. The middle meatus, which is this one, which is present under the middle concha, it will receive in infundibulum, ethmoidal bulla, or semilunar hiatus, and receive openings of the frontal, maxillary sinus, and the anterior and middle ethmoidal air cells. The inferior meatus over there, it receives the opening of the nasal lacrimal duct, which is connecting the eyes with the nose. So the lacrimal apparatus, the tears will drain into the nasal lacrimal duct, and the excessive tears will come into the nose, and then from there, from the inferior meatus, below the inferior meatus, they will be swallowed or stuff like that. So that is inferior meatus. So remember that there are three conchae, which are the bony projections coming from the lateral wall of the nose, and the place or the space below each concha is the meatus. So we have three conchae and three meatuses, and these are the structures which are present in those meatuses. Moving forward to the ethmoiditis, infection of the ethmoidal sinuses. So another point, that there are sinuses. The major sinuses are maxillary sinus. So suppose there is the face of a person, these are the eyes, and here we have a nose, and these are the lips. So the sinuses which are present in the maxillary bone, like this and like this, these are they're equal in size. Okay, so these are the maxillary sinuses. Then we have ethmoidal sinuses which are present, which cannot be drawn over here, but they're present like over here where the posterior ethmoidal cells, the middle ethmoidal cells over there. So like these are present in the ethmoidal bone. Then we have frontal sinuses which are present over here, and then sphenoidal sinuses which cannot be drawn in the two-dimensional picture. So these are the sphenoidal sinuses in a cut section, and these are the main sinuses: maxillary, frontal, ethmoidal, and sphenoidal. And we have seen the openings as well. So coming back to our discussion of ethmoiditis, so if there is infection to the ethmoidal sinuses, can erode the medial wall of the orbit, the resulting in the orbital cellulitis. So infection of the ethmoidal sinuses will erode the medial wall, because this is the ethmoidal bone, like this is the ethmoidal bone, and this is the side of ethmoidal sinuses as well. If there is ethmoiditis, so they will erode the medial wall, like this wall of the orbit, and they will result in orbital cellulitis and can spread to the cranial cavity. In orbital cavity, infection may erode the structures related to the medial wall, that are medial rectus muscle, superior oblique muscle, and the nasociliary nerve. So these branches nasociliary nerve is a branch of the ophthalmic division of the trigeminal nerve. So these divisions can be damaged. These things can be damaged within the orbital cavity during orbital cellulitis, which are medial rectus muscle, the superior oblique muscle, and the nasociliary nerve. Moving to the cheeks, point number 83. From the lateral cheeks form the lateral movable wall of the oral cavity and the zygomatic prominences of the cheek over the zygomatic bone. The first muscle is the buccinator muscle, the principal muscle of cheek. Then there is buccal fat pad, encapsulated collection of the fat superficial to the buccinator, that is like in the adults it is very small, very small in quantity, but in the newborns or babies, because they have to do the suckling activity, so to prevent the cheeks from being compressed between the upper and lower jaw, or maybe the teeth in the later in life, there is a very excessive fat pad. That is why the faces of the children, they look circular or spherical maybe. So then we have parotid duct. So the second one, like this area, where this is parotid area. So this is parotid duct. So no, that is parotid duct. This is parotid gland. So this is parotid gland, and here we have the parotid duct. So the parotid duct from the parotid gland perforates the buccinator and opens in the inner surface of the cheek, right opposite to the second upper molar tooth. Now let's talk about the movement at the temporomandibular joints. So the movements are like, I guess, forward, backward, upward, downward. So there is protrusion that is mediated by the lateral pterygoid. Then we can do the retraction, that is posterior fiber of the temporalis, deep part of the masseter, elevation, temporalis, masseter, and medial pterygoid, and depression that is done by the gravity and the digastric, genioid, and mylohyoid muscles. So these are lateral pterygoids over there, and forward movement of the mandible at the upper joint is mediated by the lateral pterygoids. All the four muscle mastications are innervated by the trigeminal nerve CN5-3, that is mandibular division of the trigeminal nerve. The temporalis, elevation and retraction, masseter for elevation, medial pterygoid for elevation, and lateral pterygoid is for the protrusion. Okay, I guess the lateral pterygoid is also responsible for downward movement of the jaw, digastric, genioid, mylohyoid. I guess the lateral pterygoid was responsible for opening of the jaw as well. So in the case of mandibular nerve, mandible, when it is protruded, deviate towards the side of region because the lateral pterygoid weakness. Yep. So it will move toward the side of region, and the opposite lateral pterygoid will be pushing the mandible to the weaker side. So this is the thing, that whenever there is mandibular nerve lesion, so the jaw will move towards the side of region. Then point number 85, that is about innervation of the tongue. So sensory, anterior 2/3, the general sensation is taken by the lingual nerve, that is a branch of the CN5-3, that is mandibular division of the trigeminal nerve, and the taste will be taken by the coda tympani nerve, that is CN7, a branch of the facial nerve. Sensory posterior, general and taste, both fibers can be taken by the glossopharyngeal nerve. The motor innervation is given by the hypoglossal nerve, that is CN12. A lesion of the coda tympani lose that there will be loss of taste sensation in the anterior 2/3 of the tongue. I'm sorry for that. So a lesion of the lingual nerve loss of both the general and taste sensation anterior 2/3 of the tongue. A lesion of cranial nerve 12 in the hypoglossal canal allows the contralateral unparalyzed genioglossus muscle to pull the protruded tongue towards the paralyzed side, deviation and atrophy of the tongue. So the tongue will move towards the side of region. Okay. Then we'll talk about palatine tonsils. So palatine tonsils are present over here. Okay. So they are present between the anterior and posterior pillars, which are made by the palatoglossal arch, the anterior one, and the palatopharyngeal arch, that is basically the posterior pillar, and the palatine tonsils are present between them. So they receive the male blood supply from the tonsillar branch of the facial artery, drained by the external palatine vein to the facial vein. Okay, so main blood supply is coming from the tonsillar branch of the facial artery, and they are drained by the external palatine vein to the facial vein. Lymph drainage mainly to the jugulo-digastric lymph nodes, which is body's most frequently enlarged lymph node as well. The jugulo-digastric lymph node is the most commonly enlarged lymph node of the body. Nerve supply, tonsillar plexus of the nerve formed by the branches of CN9 and CN10. Then so that is nerve supply, that is tonsillar plexus of the nerve formed by the branches of CN9 and CN10. So now we'll talk about tonsillitis. During the palatine tonsillectomy, the peritonsillar space facilitates the tonsil removal except after the capsular adhesion to the superior constrictor. If the glossopharyngeal nerve is injured, taste and general sensation from the posterior 1/3 of the tongue are lost. Hemorrhage may occur, usually from the external palatine vein or the tonsillar branch of the facial artery. If superior constrictor is penetrated, a high facial artery or tortuous internal carotid artery may be injured. If superior constrictor is penetrated, a high facial artery or the tortuous internal carotid artery may be injured. Okay. The glossopharyngeal nerve is injured, taste, general sensation of posterior 1/3 tongue are lost because the glossopharyngeal nerve is supplying them. So let's move forward. So here you can see in the picture, this is hard palate, and then we have the soft palate, and then uvula is over there. These are enlarged tonsils, and then you have the tongue. What is gag reflex? Gag reflex means touching the posterior part of the pharynx result in the muscular contraction of each side of the pharynx, that is called as gag reflex. Afferent limb is mediated by the CN9. The sensory pathway is mediated by the cranial nerve 9, and the efferent limb is mediated by the cranial nerve 10. Injury to the glossopharyngeal nerve CN9 will result in the negative gag reflex. So if there is injury to the glossopharyngeal nerve while we were doing the tonsillectomy, and the glossopharyngeal nerve that was present on the base of the tonsil, that was damaged inadvertently, so resultantly there will be a loss of gag reflex because the sensory component of the gag reflex is being lost. Moving forward, point number 87. 87 is about the muscles of soft palate. So tensor villi palatini and levator villi palatini elevate the soft palate during the swallowing to prevent the food entering to the nasopharynx. So these are tensor villi palatini and levator villi palatini They will lift the palate or elevate the soft palate during swallowing to prevent the food entering to the nasopharynx. The palatoglossus and the palatopharyngeus, which are present over here, the palatoglossus muscle and the palatopharyngeus muscle, which are forming the anterior and posterior pillar of the tonsils. So they depress the soft palate walls of the pharynx superiorly. Uvular muscle shortens the uvula and pull it superiorly. Okay. Then point number 88 is about the lymphatic drainage from the head. So preauricular parotid on front of the auricle, lymph node receive the anterolateral part of the scalp and lateral face. Okay, so they receive the lymph, the preauricular one, like just anterior to the ear, in front of the auricle. They receive the lymph from the anterolateral part of the scalp and the lateral face. The submandibular, in digastric or submandibular triangle, in digastric triangle, or you may say submandibular triangle, from all air sinuses, nose and adjacent cheek, upper lip, and the lateral part of the lip. Submental lymph nodes, okay, which are present, I guess, just below the chin. So submental in the submental triangle, from the chin, tip of the tongue, and the central part of the lower lip. The mastoid lymph nodes, which are behind the auricle, over there, the point number 4, these one. So they will adjacent to the region of head, and the occipital lymph nodes, which are present right over there. So they will receive the lymph from the occipital region. What is blowout fracture? So there will be teardrop sign. So in the blowout fracture, a blowout fracture of the orbital floor typically is not going to involve the orbital rim and is caused by the blunt trauma to the orbital contents. For example, by a handball, content of the orbital cavity blow out in the maxillary sinus. So they will be blowing out into the maxillary sinus. So here you can see the contents of the orbital cavity are coming down into maxillary sinus. This is called the teardrop sign, or you can see it here as well. If you can see this picture, like this thing, the contents are moving downwards, and the contents in this picture are also moving downwards. Okay, so here you can see the contents are coming down here. So blowout fractures may damage the inferior rectus muscle, infraorbital nerve from the maxillary V2, and the infraorbital artery, that is hemorrhaging artery. So the blowout fracture may damage the inferior rectus muscle, the infraorbital nerve from the maxillary nerve, say in 5-2, and the infraorbital artery, that is the hemorrhaging artery in these cases. Now moving to the point number 90, that is about the lips and palate's congenital defects. The intermaxillary segment forms when the two medial nasal prominences fuse together at the midline and give rise to the philtrum of the lip, 4 incisor teeth, and the primary palate of the adult. It forms anterior to the incisive foramen. The intermaxillary segment forms when the two medial nasal prominences fuse together, okay, at the midline, which give rise to the philtrum. So philtrum is this structure, these two lines which are present here. So the philtrum, 4 incisor teeth, like these 4 incisor teeth, 1, 2, 3, 4, and the primary palate of the adult, it forms the anterior to the incisive foramen. Got it? So the 4 incisor teeth and the philtrum of the lip and the incisive foramen, there is an incisive foramen that is given by the intermaxillary segment. Secondary palate, 2 shelves derived from the maxillary prominences. Okay, maxillary prominences are fused with the medial nasal prominences, intermaxillary prominence. Okay, so you are highly recommended to see some animation about this formation. So maxillary prominences, they will be present over here, I guess, over here and here. So they will be fusing towards each other in this direction. So maxillary prominences are fused with the medial nasal prominences, intermaxillary segment. In case of failure of this process, the cleft of the lip or palate will develop. As you can see in this picture, there is cleft lip or cleft palate in this patient. Okay. Then moving forward to the point number 91, that is about strabismus or strabismus. So strabismus means there's smart table number 9. So strabismus, it is also called as squint. So in the strabismus, the muscle is superior rectus. The action is up and medially. Testing, look laterally up, look laterally and then up. So to check the superior rectus, we ask the patient to look laterally and then upwards, and cranial nerve that supplies it is cranial nerve 3. Inferior rectus, that causes down and medial movement. So testing is done by looking laterally and then down, and supplied by the cranial nerve 3. Again, medial rectus, it adducts the pupil. So we ask the patient to look medially. Simple. Cranial nerve 3. Then inferior oblique muscle, it causes the eye to move up and laterally. So to check the inferior oblique activity, we ask the patient to look medially and then up. Right? The cranial nerve 3. So the muscle which move medially are tested by moving the eye laterally, and the muscle which move eye laterally are tested by moving the eye medially. Then we have levator palpebrae superioris. So it elevates the upper eyelid and that is supplied by the cranial nerve 3. And then we have the lateral rectus that abducts the pupil. So for checking this, we ask the patient to look laterally, and that is supplied by CN6. And superior oblique is checked. Superior oblique, the main action of that is for the eye to look down and laterally, and the patient is asked to look medially and then down, and it is supplied by the cranial nerve 4. Then we have ocular nerve palsy. External squint, or when the eye is fixed outwards, so external squint affects most of the extraocular muscles. Manifestation is ptosis. External squint affects most of the extraocular muscles. Okay. Manifestation is ptosis. Fully dilated pupil, eye fully depressed and abducted down and out. Okay. Due to the unopposed action of superior oblique and lateral rectus respectively. I don't know what the external squint means, but the symptoms are of the damage to the oculomotor nerve. So that makes sense. Listen. The oculomotor nerve is supplying most of the intraocular muscles except for the lateral rectus and the superior oblique. The function of lateral rectus is to move the eye outwards, right? So if the oculomotor nerve is damaged, the cranial nerve 3 is damaged, so the medial rectus that was being supplied by the cranial nerve is lost. Now the lateral rectus activity is unopposed and the eye is moved outwards. That is extrinsic squint. So in the case of extrinsic squint, there are a lot of manifestations which include ptosis, like you can see here. Then the eye is down and out, and then due to unopposed action of the superior oblique and the lateral rectus respectively. Trochlear nerve palsy, it causes the paralysis of the superior oblique and impair the ability to turn the affected eye inferomedially up and out. So the eye will be up and out because we cannot turn the eye down and medially. The characteristic sign of the trochlear nerve injury is diplopia, double vision when looking down, for example when going downstairs or reading. It is very important. They will tell you that the person is facing diplopia whenever he is moving downstairs or he cannot read properly because of diplopia. So this is vertical diplopia. Abducens nerve injury, it is in this eye that the eye is fixed on the medial side. Internal squint, which means that the eye is fixed on the internal edge because of injury to the abducens nerve, leads to paralysis of the lateral rectus, which leads to inability to abduct the affected eye. Affected eye is fully adducted, so it is fully adducted but unopposed action of the medial rectus. By the unopposed action of medial rectus, that is supplied by the cranial nerve 3. Now it's point number 92, that is Horner syndrome. So in the case of Horner syndrome, penetrating injury to the neck or Pancoast tumor or thyroid carcinoma may cause Horner syndrome by interrupting the ascending preganglionic sympathetic fibers anywhere between their origin in the T1 segment, intermediolateral segment of the spinal cord, and their synapse in the superior cervical ganglion. So if there is any damage in this particular vicinity, so that will result in Horner syndrome. It includes the following signs: constriction of the pupil, that is miosis. So you can see that this eye is constricted. Then drooping of the superior eyelid, that is called ptosis. So this eyelid will be dropped or may not be, as it is not evident in this picture. Then redness and increased temperature of the skin, that is vasodilation. So flushing of the ipsilateral side of the facial skin will be there. And absence of sweating, that is called anhidrosis. So miosis, ptosis, anhidrosis, and flushing will be seen in the case of Horner syndrome. Point number 93, that is about otitis media. So otitis media is basically the inflammation of the middle ear. The complications include hearing is diminished because of pressure on the eardrum and reduced movement of the ossicles. Taste may be altered because of coda tympani is affected. Infection spreading posteriorly causes mastoiditis. Infection that spread to the middle cranial fossa can cause meningitis or the temporal lobe abscess, and infection moving through the floor may produce sigmoid sinus thrombosis. Perforation of the tympanic membrane may result from the otitis media and is one of the several causes of middle ear conduction deafness. And there is a paradox that the person is in severe pain and stuff like that when he's having otitis media. As soon as the tympanic membrane ruptures, the pain is gone, because now the pressure effect of the pus that was accumulated in the middle ear cavity, that is being released. So the patient says that the the pain is gone as soon as the pus started coming out of the ear. So the tympanic membrane rupture leads to this one, but along with that the patient also complains that he has now hearing loss. Cause foreign bodies in the external acoustic meatus. Okay, we are not talking independently about the perforation of tympanic membrane. That can be a complication of otitis media, or can happen because of foreign bodies in the external auditory meatus, excessive pressure as in driving, or maybe trauma, including the noise trauma. Because coda tympani directly relates to the posterior surface of the tympanic membrane, it may be damaged and resulting in the loss of taste over the anterior 2/3 of the tongue and secretion of the sublingual and the submandibular glands. Okay. Minor perforations heal spontaneously. Large ones require surgical repair. large ones require surgical repair. Then we have inner ear. So inner ear contains the vestibulocochlear organ concerned with the reception of sound and the maintenance of balance, that is CN8. Cochlea, spiral organ of photoreceptor for hearing, located along the basilar membrane. Vestibule, cuticle and saccule are parts of the balancing apparatus, that is static position. Semicircular canal, receptors for the angular acceleration, that is kinetic, anterior in the coronal plane, posterior in the sagittal plane, and then later in the horizontal plane. So for the linear acceleration, we have cuticle and saccule, right? And for the angular acceleration, we have these three semicircular canals, which are anterior, posterior, and lateral in three different planes. Then talking about thyroid and parathyroid glands. Hormones. The thyroid gland in the body is the largest endocrine gland. Okay. It produces thyroid hormones T3 and T4, which controls the rate of metabolism, increases the temperature of the body, and calcitonin, a hormone controlling calcium metabolism, reducing the blood calcium level. But after the total thyroidectomy, patient may develop lower temperature of the body and hypercalcemia, because T3 and T4 will not be regulating the temperature and calcitonin will not be regulating the calcium. The hormone produced by the parathyroid glands is the parathyroid hormone, controls the metabolism of the phosphorus and calcium. Parathyroid hormone increases the phosphorus wasting and calcium conservation in the blood, increases calcium level. The parathyroid hormone functions opposite to that of the calcitonin. Then we have variation of the parathyroid gland position. So these are the variations. The most common side is I guess over here. 38% are over there, and so let's see that. Superior parathyroid glands more constant in the position than in the inferior ones. So superior thyroid like 13%, 11%. The superior ones are more constant in the position than the inferior ones. Inferior parathyroid glands, inferior parathyroid glands are usually inferior, near the inferior poles of the thyroid gland, but they may lie in the various positions. In 1 to 5% of the people, an inferior parathyroid gland in the deep is deep in the superior mediastinum, inside the thymus because of common embryonic origin. So 1 to 5% of the people, an inferior parathyroid gland. So in 1 to 5% of the people, an inferior parathyroid gland is deep in the superior mediastinum, that is inside the thymus, because of common embryonic origin. Then we'll talk about the anatomical relationship of the thyroid gland. So the anatomical relationships of the thyroid gland are anterolateral infrathyroid. Anterolaterally, it has infrahyoid muscles. Posterolaterally, common carotid artery that is present over here. Medial to what? Medial to trachea, right? No, medial to thyroid gland. Medial to this thyroid gland, we have trachea, pharynx, esophagus, cricothyroid muscle, recurrent laryngeal nerve. Okay, this is recurrent laryngeal nerve. This one. Then posteriorly, we have parathyroid glands to the thyroid. Okay, so these are the relationships. Then cross section of the neck. So here you can see a lot of structures in the cross section of neck. So this is sternohyoid muscle. Then this is thyroid. So thyroid muscle, then trachea is present, posterior to that. Internal jugular vein, common carotid arteries are over there. Then esophagus is also present posterior to the thyroid. Cervical cyst and the median cervical cyst. So here you can see a cervical cyst over here and also over here. Usually present as a painless midline mass on the anterior aspect of the neck, just below the hyoid bone, and moves during the swallowing together with the thyroid gland because of the relationship with the pretracheal layer of the cervical fascia and the infrahyoid muscles of the neck. A remnant of the thyroglossal canal. Thyroid gland originally forms in the epithelium of the tongue. So this cervical cyst is a remnant of the thyroglossal canal. Treatment is surgical excision. Lateral cervical cyst or the branchial cyst, which are present laterally in the neck. Lateral cervical cyst are remnant of the second, third, and fourth groove and filled up with the ectoderm. They are painless cysts located on the lateral neck along the anterior border of the sternocleidomastoid muscle. They do not move during the swallowing. Difference with the median cyst. So the lateral cervical cyst or the branchial cyst will not be moving with the swallowing, while these cysts, the cervical cysts, they will move with the swallowing. So there is a differential point between these two types of cysts. So the treatment of this one is also surgical excision, and they are painless cysts located in the lateral neck. So lateral cervical cysts, remnants of the second, third, and fourth grooves, and they are filled up by ectoderm. Talking about larynx, the point number 97 is about larynx. Cavity of the larynx, there are two folds. The vestibular folds. I'm sorry for that. So the vestibular folds which are located over here. These are false vocal cords, and then we have vocal cords, which are true vocal cords. Rima vestibuli is the gap between the vestibular fossa. So this thing, like, no, Rima vestibuli is the gap between the vestibular folds, while the Rima glottidis, that is the gap between the vocal folds. This one is the Rima glottidis. Gap between the vocal folds anteriorly and the vocal processes of the arytenoid cartilage posteriorly is the most narrow place in the larynx. It limits size of intubation tube. It limits the size of intubation tube during the endotracheal anesthesia. What are the muscles of larynx? There are abductors, and then we have, okay, so what are the abductors? The abductors include posterior cricoarytenoid. The posterior cricoarytenoid is over here. It abducts the vocal folds, the only abductor of the vocal fold, the posterior cricoarytenoid. It is innervated by the recurrent laryngeal nerve C10 vagus. Interruption of the recurrent laryngeal nerve results in the hoarseness because the corresponding vocal folds does not abduct and deviate towards the midline. If there is damage to the recurrent laryngeal nerve, so there will be hoarseness because the corresponding vocal cord does not abduct and deviate towards the midline. Okay. So this is lateral cricoarytenoid, and then we have the lateral cricoarytenoid ligament and the vocalis muscle and transverse blah 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 blah. Okay, so moving to the point 198, that is about cricothyroidotomy. Cricothyrotomy. A cricothyrotomy is an emergency procedure that leaves the airway obstruction, for example, swallowed foreign bodies or the normal tissue growth. A hollow needle is inserted into the midline of the neck just below the thyroid cartilage. Needle thyrotomy. So here you can insert the needle. More frequently, a small incision is made in the skin over the cricothyroid membrane, and another one is made through the membrane between the cricoid and thyroid cartilage. A tube that enables the breathing is inserted through this incision. So here you can see obstruction and breathing is over there, thyroid cartilage is over here, then cricothyroid membrane, larynx, and the cricoid cartilage. Point number 99 is about the retropharyngeal space. So this thing is called the retropharyngeal space, like present posterior to the pharynx. It is interval between the pharynx, buccopharyngeal fascia, and the prevertebral fascia. So the interval between the prevertebral fascia, this pink one, and the buccopharyngeal fascia, that is the yellow one. So between yellow and pink structure, we have a space, potential space, that is called as the retropharyngeal space. It may provide a passage for the infection from pharynx to the posterior mediastinum. Mediastinitis and that is fatal 90% of the times. Then moving to the 100th point, that is about the neck axillary sheath. So it is derived from the prevertebral fascia. Okay, it encloses the subclavian artery and the brachial plexus as they emerge in the interval between the scalenus anterior and medius muscle, interscalenus space, and extends into the axilla. Now we'll talk about torticollis. So torticollis, it can be congenital or spasmodic torticollis. So the congenital torticollis most commonly caused by the fibrous tissue tumor in the sternocleidomastoid muscle. Head turns to the side and face to turn away from the affected side. Okay, so face will be turned away from the affected side. Okay, fibrous tissue tumor in the sternocleidomastoid, and head turns to the side. Head turns to the side and face turns away from the side. So head is turning to the side while the face is turning away from the side. From the affected side, surgical release may be necessary. In spasmodic torticollis, listen, the sternocleidomastoid pushes the head toward the opposite side. If this muscle gets shortened, suppose if this muscle is shortened, so this will cause the head to move toward the side of region, but the face will be moved to opposite to the side of region. Okay. Spasmodic torticollis may involve the bilateral combination of the lateral neck muscles, usually the sternocleidomastoid and trapezius. Involuntary shifting of the head laterally or anteriorly. Shoulders usually elevated and anteriorly displaced on the side on which the chin turns. Shoulders usually elevated and anteriorly displaced on the side to which the chin turns. The posterior triangle of the neck. So this triangle is called the posterior triangle of the neck. So the posterior triangle of the neck, the veins are external jugular vein and subclavian vein. Arteries are occipital artery. Nerves include accessory nerve, cranial nerve 11, trunk of the brachial plexus, branch of the cervical plexus, and the phrenic nerve. Lymph nodes include superficial cervical nodes along the external jugular vein. Cranial nerve 11 is the accessory nerve supply. It supplies the sternocleidomastoid muscle. Face look upward to the opposite side and the trapezius muscle, superior fiber elevate and middle fiber retract and the inferior fiber will depress the scapula. So this was all about the read with me sessions for the 100 points. We're done with that, alhamdulillah. So see you in the next session. I guess it will be about the U world. So until then, Allah Hafiz and Fi Amanillah.